So tonight we're going to talk about anger, hostility, and aggression first. So the objectives for tonight, we're going to be able to describe anger, hostility, and aggression. We're going to describe psychiatric disorders that may be associated with an increased risk for hostility and physical aggression in clients. Describe the signs, symptoms, and behaviors associated with the 5 phases of aggression. Describe important issues for nurses to be aware of when working with angry, hostile, or aggressive clients. Discuss the characteristics, risk factors, and family dynamics of abuse and violent behavior. Examine the incidence of and trends that we see in domestic violence, child and elder abuse, and rape. Describe behavioral and emotional responses to abuse. Apply the nursing process to the care of the clients who experience abuse and violence. Provide education to clients, families, and communities to promote prevention and early intervention of abuse and violence, and then evaluate your own experiences, feelings, attitudes, and beliefs about abusive and violent behavior. All right, so anger. Anger is considered a normal human emotion. I think all of us can admit, probably just last night, that we were all angered about something, or on Tuesday night when you took this exam. Anger results when a person becomes frustrated, when they feel hurt, or they are scared or afraid. Anger is a strong, uncomfortable emotional response to frustration as perceived by individuals, and we all perceive anger differently. When anger is handled appropriately, it can be a positive force for helping to resolve conflicts. It can help to solve problems, and it can ultimately help us make decisions regarding different situations. It does signal that fight or flight response in our body. And when used inappropriately, anger can cause physical or emotional problems, and it can interfere with relationship. So when it's expressed inappropriately, or if we keep it inside and we suppress it and we don't talk about it, it can have damaging effects. So when anger is denied, so when we don't have the opportunity to talk about it, if we are not able to express ourselves, or if we suppress anger, or if we express it in an inappropriate way, such as aggressive behavior, that is when anger is viewed as negative. As nurses, we need to help teach our patients to use therapeutic communication. So when a patient is angry about something, we want to teach them to use I statements. So they can say, I'm very angry about what I'm seeing right now, or I feel this when I get treated like this, or I am not comfortable with the way things are going. So we want to encourage our patients to use those I statements. So it allows them to be able to express themselves, but it allows them to express their anger in a positive way. It's not inappropriate. It allows the appropriate expression, of anger, and it can lead to productive problem-solving discussions and reduced anger. Catharsis is when people express their angry feelings by engaging in aggressive but safe activities, such as hitting a punching bag or yelling. Engaging in these activities can increase sometimes rather than alleviate angry feelings. So some of these activities may be contraindicated for certain patients that suffer with anger issues. Activities that are not aggressive, such as taking a walk or sitting down and talking with another person, are definitely more likely to be effective when we think about decreasing anger in a certain situation. So we have hostility and aggression. So hostility is verbal aggression. So it is an emotion that is expressed through verbal abuse, lack of cooperation, violation of rules or norms, or a threatening behavior. Sometimes we see hostility being expressed when we feel threatened or if we feel powerless. Usually when we see hostile behavior, it is used to intimidate or cause emotional harm to others, and it can also lead to physical aggression. So physical aggression is an attack on or injury to another person, and it can also be destruction of property. So verbal and physical aggression are meant to hurt, harm, or punish other people, or to ultimately force them to do something that we want them to do. Sometimes behavior can be very sudden and unexpected. Sometimes we can also see the behavior escalating and we can think in our minds, okay, this is going to get out of control. I can see that this patient is getting closer to becoming physically aggressive. So as nurses, we just have to be aware of that. And we have to be able to identify our patients in these stages or phases. So we have the triggering phase. We're going to talk about these in detail. The triggering phase, the escalation phase, the crisis phase, the recovery phase, and the post-crisis phase. Some psychiatric disorders can cause hostile and aggressive behavior. So some of our patients suffer from what we call paranoid delusions. So they don't know why they feel this way. To them, they think that it's real. They can't help the thoughts that they have. They believe that people are trying to harm them. They believe that people are out to get them. And sometimes they engage in hostile or aggressive behavior because they are trying to protect themselves. So they act out. Patients that hear auditory hallucinations, they hear voices telling them to hurt themselves, hurt others. So as a defense mechanism, they sometimes become hostile and they participate in aggressive behavior, again, because they're trying to protect themselves. Anytime we have patients with dementia, delirium, or head injuries, we can see a possibility of hostile or aggressive behavior. All the time at work, when I work night shift, I see these little old men and women who have dementia. They get so confused at night. They have that sundowning. And what they're experiencing is real to them. They can't find their family. They can't find their friends. They don't know where they are. They think that people are trying to hurt them. So when we try and teach them to stay in their room or stay in the bed, they think we're doing something to hurt them. So they act out by being hostile and being aggressive. We know that intoxication with alcohol or other drugs, there's always the potential there for people to lose control and become hostile or aggressive. Patients that are antisocial with borderline personality disorders, they're also at risk for developing anger and hostility issues. Patients that suffer from depression, sometimes they have a sudden intense spell of anger. We usually see this in situations where they feel emotionally trapped, and that's how they handle things. They all of a sudden just get very hostile and aggressive. It's very sudden. It comes out of nowhere. Then we have patients that have what's called intermittent explosive disorder. This disorder is very rare, but it is characterized by aggressive impulses that result in serious assaults or destruction of property. So behavior with this disorder is grossly disproportionate to any provocation or precipitating factor. So an example of this would be if someone went to McDonald's and they got a small fry instead of a large, and they just went on a rampage and started busting up everything in McDonald's. So to you or I, where we might be upset, we certainly wouldn't try to hurt people or destroy property. So it's going to be very disproportionate. And then we have acting out behaviors. So acting out behaviors are caused by immature defense mechanisms. So this is when our patients deal with an emotional confliction stressors through actions rather than through reflection or feeling. So instead of taking the time to really stop and reflect and think about things and try and be in touch with their feelings, those defense mechanisms are very immature and they just act rather than thinking. So what is the etiology of hostility and aggression? So we have neurobiologic theories. So through different studies, they actually are not able to identify one single cause that contributes to hostility and aggression. They do believe that serotonin plays a role. They believe that low levels actually contribute to increased aggressive behaviors. They also have discovered that increased activity of dopamine and norepinephrine in the brain is also associated with increased impulsive, violent behavior. Any kind of structural damage to the limbic system, any kind of damage to the frontal or temporal lobes can also cause issues with hostility and aggression. So there are also psychosocial theories to look at. So some believe that the failure to develop impulse control is just the ability to delay gratification. So instead of, some people are very good with, some kids are very good with when they get an allowance, they can wait to buy something. When we talk about delayed gratification, some people are not good with that. So maybe your son or your daughter has been saving money for quite some time to buy, the latest Xbox, but she only has $200 and she can't afford it. So instead of waiting and saving more money to get the one they really want, they'll just buy the, maybe an older one just because they have to have one. So that's delayed gratification. We see it in children that come from dysfunctional families where there's poor parenting, or children who receive inconsistent responses to their behavior. So we see this a lot in families who sometimes if they get a response from their parents all the time for negative behavior, but they don't get anything when they have positive behaviors, then children just learn to only respond to negative behaviors. And then sometimes just being inconsistent. So doing what we say we're going to do. So if we tell little Johnny that if he spits on his sister one more time, that he's going to have to sit for 10 minutes, then when he does that, then we need to be consistent. And then we also see it with children from low socioeconomic statuses are also at an increased risk. Patients that have been subjected to rejection can lead to anger and aggression when that rejection causes the individual emotional pain or frustration, or it can become a threat to his self-esteem. So we see this a lot in violence between spouses and adults and things like that. Rejection and aggression can also be the basis for long-term problems that regulate and manage their emotions, including anger. And then aggressive behavior is seen as a means of reestablishing control and improving the mood. So sometimes people that are aggressive and controlling, it boosts their self-esteem, it makes them feel better about themselves. And if they feel like they're in control, that's very satisfying for them. And then, of course, we always have cultural considerations. So in certain cultures, it is believed that expressing anger can be seen as rude or disrespectful, and they avoid it at all costs. So this is very common in the Asian and American Indian culture. They try to, we want to try and help the client express anger verbally to an authority figure. Doing that would be unacceptable. So we would never want to encourage them to express anger because it's not what their culture believes. There are some culture-bound syndromes that involve aggressive, agitated, or violent behavior. So Hwayong is seen in Korea. It's predominantly seen in women. It's an illness that is caused by the suppression of anger. They also call it the fire illness. Symptoms would be uncontrollable sighing. The patient can have abdominal pain. They can report trouble sleeping. They can be irritable, anxious, and also depressed. In West Africa, we can see something called buffet delirante. So this is a sudden outburst of agitated and aggressive behavior. You will also see confusion and psychomotor excitement. These episodes can include visual and auditory hallucinations, and it can cause the patients to feel paranoid. And all of these symptoms can resemble brief psychotic episodes. They don't last long. And then we have amok, which is seen in Malaysia, Laos, and Philippines. This is characterized by a period of brooding, followed by an outburst of violent, aggressive, or homicidal behavior directed at other people and also at objects. Usually, this behavior is precipitated by a perceived insult and is usually only seen in men. So, risk factors for hostility and aggression. So, any patient that's had a history of aggressive issues, having poor impulse control and a violent history. Any patient that has poor coping skills or limited support systems. If we don't have support systems, we're not going to have good coping skills. Any comorbidity that leads to acts of violence, so those psychotic delusions, hallucinations, and then violent, angry reactions that we see with certain cognitive disorders. People that live in violent environments or grow up in violent environments. It is a learned behavior. And then as we want to do as nurses is that our priority is going to be to always make sure that we set limits within the therapeutic milieu. So signs and symptoms of patients that are exhibiting issues, that are exhibiting hostility or aggression, or if they're getting ready to. So sometimes our patients will seem very hyperactive. They might be very, very restless in their seat. They might be fidgeting with their hands, rocking back and forth, or if they're standing up, they could be pacing back and forth, looking back and forth at what's going on. When you talk to them, they can become very, very defensive, especially when you criticize them. It might not even appear to you that you are criticizing them, but that's the way they see it, and they're very easily offended. Sometimes you can have eye contact that is very, very intense, that it makes you feel uncomfortable. That patients won't break the eye contact for any reason. It's a control issue, or sometimes they won't make eye contact with you at all because of the thoughts that they're having, and they know they're about to do something. We might see facial expressions such as frowning or grimacing, and then their body language. So, are they sitting in the chair? Are they very, very comfortable? Are they rocking back and forth? Are they clenching their fists? Are they waving their arms around? What does their breathing look like? Is their breathing relaxed and they seem completely normal? Or are they breathing really heavy? Again, there's aggressive postures, leaning forward, appearing tense. How do they sound verbally? So are they starting to talk loud? Are they getting louder and louder? Are they saying things that seem aggressive? Are they talking very fast? And then have they been taking any type of drugs? Or are they intoxicated with alcohol? So what do we do to treat hostility and aggression? So the first thing we're going to do is we're going to treat any underlying issue or comorbidity psychiatric diagnosis that the patient is suffering with. So patients that have schizophrenia or bipolar disorder, we can give them lithium. So lithium is for bipolar and conduct disorders. And we also give it to some patients who are suffering with intellectual disabilities. We can also give carbamazepine or valproic. This is given for patients that have aggression associated with dementia, if they have some type of psychosis, or if they're suffering with personality disorders. And then we can use those atypical antipsychotics, so your clozapine, your risperidone, your Zyprexa. We would give these to patients that have aggression associated with dementia. You'll see that Zyprexa is like the gold standard. We give that to all of our patients with dementia that are having those aggressive outbursts. We can also give it to patients who are suffering from brain injuries, patients that have intellectual disabilities, and then those personality disorders. And sometimes we can see, when we talk about brain injuries, if we think about cancer patients that may have cancer of the brain, or if they have metastatic disease that is spread to the brain, these patients become very, very confused as the disease progresses, and they kind of become like those dementia patients. They can get very angry, they don't know what's going on, they can become very defensive. So that's just another thing to keep in mind. We can give benzodiazepines because they're going to help reduce that irritability and control that agitation that we see in older adults with dementia. A lot of times we use Haldol and Ativan together as a combination to help decrease agitation or aggression and those psychotic symptoms. And atypical antipsychotics are always going to be more effective than those conventional antipsychotics for aggressive psychotic clients. So those are the ones that we usually go to. And then we just want to remember that those atypicals have those extrapyramidal side effects. So we need to monitor them closely. And some of those unpleasant side effects can be treated with Cogentin. So this is the those extrapyramidal side effects, again, that we talked about a couple weeks ago. So you have that pseudo-Parkinsonism, you have the acute dystonia, the tardive dyskinesia, and the akathisia. So I will let you guys read more about that. So the nursing process. So what do we want to do as nurses when we're assessing these patients? So we want to look at any factor that's going to influence our patients to become hostile or to have any type of aggression in their environment. Or we talk about that unit, that milieu. That milieu is that common area where all the patients sit out. It's very important that the staff has very clear roles. So there could be 3 or 4 nurses, maybe a medicine tech, maybe a CNA. It's very important that all of those members know exactly what their role is. So one person is going to sit at this side of the room. One person is going to be the one who gets involved if there is, like, you know, an aggressive issue. The other person's going to go get the doctor. Everybody needs to know their roles. When all of the staff knows their clear roles and they know exactly what to do, studies show that aggressive behavior is less common. They can present with a united front, and patients will know that there's going to be zero tolerance for any unacceptable behavior. And then if something does happen, the staff is ready and engaged to handle the situation. We also want to make sure that the staff can have planned adequate events. So we want to keep our patients busy. We want to promote client interaction so that we can interact with our patients and we can try and get a good idea of their mental stability, how they're feeling, what kind of a mood they're in. We want to engage them in group interaction. If patients are bored, they tend to feel frustrated. They're alone with their thoughts, which sometimes isn't good if patients are hearing voices. And then aggression is usually more common and intense. So we want to make sure that we're keeping them engaged in certain activities. And then we want to look at patients individually. So each patient, especially in mental health, we have to look at them individually because all of their background, their history, their issues that they're dealing with are going to get completely different. So we want to look at their past history. Do they have a history of violent or aggressive behavior in the past? If they have, we know that these are going to be good indicators that they're going to have, or they could have aggression in the future. So when we talk about their past history of violence, so have they been violent? Have they hurt other people? Have they been hurt by other people? Did they grow up in a household where they were abused on a regular basis? Were they a victim? Or do they have any type of substance abuse addiction? We know that patients that have addictions to substance abuse have a much more likelihood of developing aggressive behavior. And then we want to be able to determine how our clients handle anger and what is helpful to controlling it. So that is, we've been talking about this, that one of the ways that we can gauge our patient's stress and how they handle and how they're going to handle something is to determine how they've handled things in the past. Talk to them about it. What is helpful? What do they normally do when they feel like they're getting hostile? Is there, do they have a certain regimen that they like to do? Do they count to 20? Do they take 10 deep breaths? What is helpful for them? And what have we seen them do in that environment when they're in that hostile environment? When patients believe that people are not listening to them, they get angry and they get hostile. So we want to make sure that we always acknowledge our patients and that we actively listen to them. And then we have to determine what phase of aggression cycle that our patients are in, because if we know what phase they're in, we can know what to expect and we can know the appropriate interventions to give them. So if you look on page 180, or table 111.1, you will see the 5-phase aggression cycle, and it goes into a lot of detail. But this is it right here. So this is the triggering phase. So during the triggering phase, there's going to be an event or a circumstance in the environment that causes the client to respond in some way, usually anger or hostility. The patient's going to be restless. They might be anxious. They're going to be irritable. They're going to be pacing. They're going to have muscle tension, rapid breathing, perspiration, and their voice is going to get loud. And you're going to tell that they're angry. So when you see that behavior in a patient, you're going to know that, hey, something's going on with this patient. They're getting ready to probably become very angry and they are going to maybe engage in physical violence. So that's the triggering phase. Escalation phase is when the client responds to escalating behaviors that indicate a movement towards loss of control. So the patient may be pale or have a flushed face. They may be yelling, they're swearing, they're visibly agitated. Maybe they're threatening the staff or other people. They're being very demanding. I want this, I need this, you're going to do this now. They have clenched fists. They have threatening gestures, so they're getting close to patients, they're getting in their face. They're going to be very hostile. They're going to have a loss of ability to solve the problem or to think clearly. And then we're going to enter that crisis mode. So this is during an emotional and physical crisis where the client loses control. So they have a loss of their emotional control and their physical control. So they could be throwing objects, they could be kicking at staff members, hitting other people, spitting, biting, scratching, screaming, shrieking. And then they're definitely, during this phase, will not be able to communicate clearly. And then things kind of start to wind down. We have the recovery, so they kind of get that all out of their system and the client regains physical and emotional control. You're going to know that their voice starts to lower, their muscle tension is going to decrease. They're going to become, their communication is going to be more clearer and a little more rational, and you're physically going to be able to see them relaxed. And then post-crisis, this is where the client attempts reconciliation with others and returns to the level of functioning before this aggressive episode started. The client will probably show remorse. He's going to be very apologetic. They're going to be crying because ultimately they didn't want to engage in this. This is not what they wanted to do. So they're going to be apologetic. They might be quiet and they might even be withdrawn in their behavior. So if we're going to be able to to really look and see when these events are going to occur, then we have to know these 5 phases of this aggression cycle so we can know what to recognize and we know what's coming next and what interventions we know are going to be effective for our patients. So nursing diagnosis that we will see, we can see anxiety related to situational crises. We can have defensive coping related to inability to acknowledge responsibility for their actions and for their result of actions. We could have fear related to an environmental stressor or just being hospitalized. Fear related to real or an imagined threat to their own well-being. So those are our patients that have the auditory hallucinations, the visual hallucinations. Powerlessness related to healthcare environment, and then risk for self-directed violence. So we know those risk factors are going to be the history of violence, a history of abuse, and rage reaction. So outcome identification. So the patient ultimately will not harm themselves or others, and that they will not threaten others. We want the patient to refrain from intimidating or frightening behaviors. So raising their fist, making those them bodily gestures, running around the room, throwing objects. We want our patients to be able to describe their feelings and concerns without escalating into that aggression period. And then ultimately they will be compliant with their treatment. So interventions. So when we see a patient that is hostile or verbally aggressive, it can be very intimidating and frightening, not just to the patients, but to the nurse and the staff as well. I'm not sure that that's anything that anybody, regardless of how long they've been doing it, is ever comfortable with. The most effective and least restrictive interventions when implemented early in the cycle of aggression are going to have the most positive outcomes. So we want to see those triggers, see when that patient is starting to go towards aggression or that hostile behavior, and then we want to, kind of head it off, and we want to do interventions that are going to be the most effective, but also the least restrictive. So we wouldn't see a patient that got up and started swinging his arms and maybe said he was angry. We wouldn't take him and put him in seclusion and put restraints on him. That wouldn't be considered the least restrictive. We would want to try everything else first. So sometimes in social settings, people tend to get far away from the interaction. You'll see other patients that see that something's going to happen and they'll get up, they'll move far away. You'll see staff members sometimes when they see that things are starting to escalate, they will get up and they'll move away. In psychiatric settings, we want to engaging the hostile patient in dialogue is usually the most effective in preventing the behavior from escalating to the physical aggression. So we want to recognize what's happening, and then we want to be able to talk to them. So we kind of want to call them out on their behavior in a respectful way and try and kind of like talk them down off the ledge and really find out what's going on. So we talked about that environmental management. So we want to make sure we have planned activities for all the patients. So playing cards, watching movies, informal discussions that don't lead to aggression. We want to promote for patients to be able to talk when they're calm, because that is going to minimize their boredom. So some patients in the milieu don't want to talk. So we want to encourage it, but we don't want to make it mandatory. We want to schedule one-on-one interactions. This lets our patients know what to expect, but it also makes our patients feel safe. Assistance with problem solving or conflict resolution to help avoid expression of anger. So we said earlier that anger is a normal feeling, and that if we can express it in a safe way, then it can be a positive thing. So we want to encourage our patients to express their feelings appropriately. So we want to use those assertive communication statements. Like we said, we would want to say, I noticed that you seem very upset right now. Tell me more about what you're feeling. We want to encourage the patient to also do the same thing, using those I statements. Well, I get really upset when I try to sit in this chair and James keeps staring at me. So you're diverting the situation, they're effectively communicating, and you're de-escalating the situation. And negotiating is also an important skill. So safety of other patients who may need protection from the intrusive or the threatening demeanor. So we ultimately have to protect the patient who is getting ready to be violent, but we have to also protect all the patients around them who are not, who could be subjected to that patient's abuse. So we want to make sure that if we see that something's going to happen, we want to move patients out of the way. We want to get them to another room, try and intervene as early as possible to protect everyone, staff members and the other patients. When an incident does occur, we want to make sure that we follow up and talk to those clients about their feelings, because it can make them feel very uncomfortable. They can be scared. Their safe environment may no longer be safe for them. They might feel that way. And then we, of course, as the staff members, are going to want to closely supervise that aggressive client to keep him from hurting anyone. So we are going to talk about the different phases. So when we are managing aggression, we're going to talk about that triggering phase. So we have to approach the patient in a very non-threatening, calm manner, because the ultimate goal is to de-escalate the behavior. Our approach should be very clear. It should be very simple, and we should have a short statement. So, James, I can see that you seem very upset right now. Talk to me about what you're feeling. Short, simple, and to the point, using those I statements. You want to allow the client time to express him or herself. Sometimes, depending on the medication they're on or how worked up they're getting, they might not really be able to just sit down and say, this is how I feel. So you want to make sure that you are actively listening to them, convey empathy so that they know that you're taking him seriously. If people feel like you're not listening to them, it's just going to escalate things. We can always suggest that the patient go to a quiet area. It gives you time to talk and not, maybe the patient feels embarrassed. So it'll take him away from other people, and it ultimately keeps other people safe. If you have to, you can use those PRN medications. So some patients know that they need to take medications when they feel that way, and they'll take them. Some of them are very much against it. So you want to offer them, but during this triggering phase, this is not where we would mandatorily make someone take a medication or give them a medication through like an IM route. So we could just offer them. We encourage the client to express his or her angry feelings verbally. The patient is still in control and can maintain that control. And then we can suggest taking a walk or any other kind of activity that would take their mind off of things. So the escalation phase, this is where the client is building towards loss of control. So sometimes we as the provider might have to take control. So now we are going to provide firm directions in a calm voice. James, your behavior is not acceptable. I need you to come over here to the seat. I need you to sit down. Your behavior is causing other people to feel uncomfortable. So now we have to take a little bit more of a control. We have to direct that patient to a room or a quiet area for a timeout. And again, offer those PRN medications. We want to firmly let the patient know that their aggressive behavior is unacceptable, but that we are there to help them to maintain and regain control again. If ineffective, this is where we have to obtain help from other staff members. This is where we have to use what we call a show of force. So usually we have 4 to 6 staff members that are ready within the sight of the patient, but they're not as close as the primary nurse. So this is going to indicate to the patient that the staff will control the situation if they have to, if the client cannot do so. So now we have the crisis phase. So the patient is now physically aggressive. So the staff has no other choice but to take charge of the situation for the safety of the client who is aggressive, the other staff members, and then the other clients in the milieu. We are going to inform the patient that his behavior is out of control, and then we are going to use restraints or seclusion only if necessary. So after we go over to the patient, we tell him that he's out of control. If he's not listening and other people are at risk, then we're going to use those restraints. We only use restraints and seclusion based on your facility's protocols and standards. They're all different, so we're not going to get into a lot of that, but you would follow your facility's protocols. And then if you do have to use restraints or you do have to put a patient into seclusion, you have to make sure that you get a physician order as soon as possible. That's just according to your facility's policies. Some people might say 4 hours, some people might say 1 hour. So again, whatever your facility says. So you would only use restraints or seclusion if your patient is very aggressive and there is an immediate danger to himself or others. And then if all other means of calming the patient were deemed unsuccessful, and then if a legally detained patient is threatening to escape. So sometimes people will say, I'm not staying here anymore, I'm leaving. Then that would be an opportunity for you to restrain them. So now we have the recovery phase. This is where the client restarts to regain control. So it's very important during this phase that we go back and discuss ways that the patient could have kept control during that aggressive cycle. So what could we have done? When did you recognize that you were starting to lose control? What made you so angry? What could we have done differently? We want to encourage the patient to talk about the incident. We want to know what triggered him, what escalated him from the patient's perspective. And then we want to explore those alternatives to preventing that aggressive behavior. We want to make sure that the patient is relaxed. He might need something to sleep. We can encourage him to get some sleep. And then we want to debrief the staff to evaluate the effectiveness of the actions that we took. So did we do what we were supposed to? Did we not do something that caused this to escalate? What should we have done? What could we do better? What would we change and do different next time? We want to make sure that we assess the staff members and the patients for any type of injuries. Did anybody get hurt during that whole aggressive situation? And then we're going to provide documentation of any injuries of the patient and the staff. And then we would debrief the staff again about everything that happened. We also want to make sure that we document the entire incident completely. We want to include all of the behaviors that led up to the aggressive episode and those that were observed through the critical incident. We want to discuss and document any nursing interventions that we implemented and how the client responded to them. So did we have to give an IM injection of Haldol? How did he respond? Did we have to use restraints? How did he respond? Did we implement less restrictive measures first? So we tried to use firm language to calm the patient down. We brought him into another room. These are the things we tried but didn't work. So we have to show that we tried to do X, Y, and Z before we did the most restrictive thing. And then if you do the most restrictive thing, you have to document how the patient tolerated it. And then the post-crisis phase, this is where we will go back and we will remove the patient from any restraint or seclusion because their behavior is now appropriate. They are welcome to rejoin the milieu as soon as they can meet the behavioral criteria. We want to make sure that we calmly discuss their behavior. We don't want to lecture them and we don't want to chastise them. Once they meet the behavioral criteria, we want to allow them to return to their activities and their groups, what their normal activity was prior to the event. And then we want to get feedback for regaining control with the expectation that he or she will be able to handle their feelings or events in a non-aggressive manner in the future. And then we want to focus on how the patient can appropriately express their feelings, resolve any fears that they have without being aggressive or hostile. So then our evaluation phase. So was the patient's anger diffused in the early stage? Were we able to recognize this this hostile period brewing before it escalated? We said early on that care is most effective when that client's anger can be diffused in an earlier stage. So were we able to recognize it in that stage? And then we know that restraint or seclusion is sometimes necessary to handle that physically aggressive behavior. The ultimate goal is to help teach the patient that the patients that are angry, hostile, and potentially aggressive to express their feelings verbally and safely without threats to the staff or the other patients or destruction of property. So next we're going to talk about workplace hostility. So in July of 2008, the Joint Commission decided that intimidating and disruptive behaviors in the workplace were a real issue. So they issued what they called a Sentinel Event Alert. So they said that any intimidating or disruptive behaviors in the workplace that undermine a culture of safety and lead to errors, decreased patient satisfaction, preventable adverse outcomes, increased health costs, and loss of qualified personnel would no longer be tolerated. Included in those disruptive behaviors would be verbal outbursts, physical threats, as well as passive activities, such as refusing to perform an assigned task or doing things with an uncooperative attitude. We see these issues often demonstrated by healthcare providers that are in powerful positions. So they refuse to answer questions, they refuse to return phone calls, they refuse to answer pages in the hospital if someone's calling them. They can be very condescending, they can intimidate their employees, they may speak to them using language or tone that is non-friendly, unaccepting, and intimidating. And then they can also be viewed as not having patience. JCAHO also added what they call lateral or horizontal violence. This is bullying in the workplace. That was added to the initiative back in 2016. This is another Sentinel event alert that they will not tolerate in their accredited organizations. Bullying is defined as an abusive conduct, such as verbal abuse, threatening, intimidating, or humiliating behaviors, and work interference. So sabotaging someone's work, which prevents people from being able to accomplish their job. So JCAHO developed these new standards of leadership. So they now require that all accredited healthcare organizations must have a written code of conduct that defines acceptable and non-acceptable, disruptive, inappropriate behaviors. Everyone in the hospital has to have access to it. They require that the leaders of the organization create and implement a process for managing these behaviors. So if employees do bully other people and they try and sabotage their work or they verbally abuse them, what is the hospital going to do to manage these behaviors? There has to be some type of disciplinary action. And then the hospital must also educate all employees regarding what they feel that their expected professional behavior is, and that the healthcare organization will have a zero tolerance policy that all are accountable, from the CEO all the way down to the housekeeper. They must also create and implement a process for managing those disruptive and inappropriate behaviors. All right, so community-based care. So in order for us to effectively control aggression in patients, we have to manage their psychiatric disorders. So that means that patients in the community have to regularly follow up to their appointments. Most cases, especially when they're first being managed and they're starting initial medications, we know from our future lectures that from our previous lectures, that they have to keep coming back to the doctors to reevaluate that medication. Is it working? Do we need to up the dose? Do we have to lower it because you're having too many side effects? We also know that with some of these medications, because of the scheduled class that they just can't be prescribed in 3-month increments. So they can't just get a 90-day supply. They have to come to the doctors every 30 days or call in, have a telehealth appointment to get that prescription again. So they need to have those regular follow-up appointments. And then we need them to be compliant with their prescribed medication. So we as the nurses need to educate them that they first may not see a complete change in their symptoms within the first 3 weeks. Sometimes it takes 4 to 6 weeks, that we might have to change their dose a little bit. We might have to increase it to get the desired effect. We want to educate them about those uncomfortable side effects that may dissipate after the first 2 or 3 weeks. Remember, we don't want them to say, I'm not taking this anymore because it gave me dry mouth. Well, the benefits may outweigh the risks, and in 2 or 3 weeks, you might not be having that symptom anymore. So we need to do everything we can to make sure patients are compliant with their prescribed medication. And then we want to encourage them to participate in those community support programs. So if they're meeting, if they're going to a Narcotics Anonymous meeting or an Alcohol Anonymous meeting or any type of self-help group, we want to encourage them to, actively participate in those groups. There are anger management groups that can help patients learn how to effectively express their feelings in a safe way. They can help them develop learning, problem-solving skills, and teach them how to handle conflict resolution. When we do see assaults that happen to staff members by clients in the community, usually it is caused by hospitals or your, not just your ERs or your regular hospitals, but your mental health institutions, they discharge the patients much sooner than they should be. And we said earlier that we see this happening because we don't have the beds to accommodate the patients. And if their conditions aren't as serious as some others, then they kind of get bumped and we put them back in the community. And then when we put them in the community, we don't have the resources to help manage their mental illness. So it's kind of a revolving door. We see patients that have stressful living situations. They have increased access to alcohol and drugs. They have the availability to get lethal weapons. And then obviously if they're not compliant with their medication. Statistics show that episodes of assault were often precipitated by a denial of services, acute psychosis, and excessive stimulation. So self-awareness. So the nurse has to be aware of how they deal with anger before we can help other people. So if we are afraid of angry feelings, we may avoid clients when they become angry. If we avoid them, that allows the client's behavior to escalate, and it lets the patient know on a subconscious level that we're tolerating that behavior because we're avoiding it. So if we're uncomfortable with anger, that's going to be communicated on a subconscious level to our patient, and things can escalate. If our response to patients is to respond with anger, then obviously that situation is going to escalate into a power struggle. The nurse then loses that opportunity to be able to talk down the client's anger. So we want the patient to have respect for us. We don't want to engage in that power struggle. And then we have to have and know our own methods of how we handle our own angry feelings. We need ongoing education and practice of those safe techniques that are needed to help minimize or avoid injury to both staff and clients. So usually the facilities that you work for, they offer a lot of these programs for you to take. There's things on the outside you can do on your own, but if you're in these situations, you need to know how to diffuse these situations. So you need to practice those safe techniques. You need to practice your use of assertive communication skills, and you need to learn how to resolve conflict that comes up. You need to be comfortable with the expression of anger from others. So you have to realize that the anger isn't really directed towards you. It's directed towards someone else, but because you're so close to them, they're taking it out on you. You can't take it personally or measure or use it as a measure of effectiveness as the nurse. So because the patient is angry and because he's aggressive doesn't mean that you as the nurse didn't do what you were supposed to do. You can be doing your job completely exactly like you were trained to do, and the client still decided to be aggressive and hostile. You must have the ability to be calm, non-judgmental, and non-punitive. All right, so a couple questions. A nurse observes, whoops, hold on, the answer's down there. A nurse observes a client who has a history of aggressive behavior towards others, swearing and kicking the furniture in the day room. Based on the client's behavior, what should be the nurse's overall immediate priority of care? A, de-escalate the client's agitation. B, provide for a safe therapeutic milieu. C, assess the client's agitation level. Or D, eliminate the source of agitation.
Assess. Assess C.
A.
What else do you guys think?
A.
Is it B?
B.
D.
All right. So
I would say A, because you're not going to worry about getting to a safe place until you get the client calmed down. That would
I
be
agree with Kathy.
that would be my first thought.
okay. So we know right now that this client has a history, we know it, of aggressive behavior. He's kicking, and we know that this is his potential. your immediate priority is going to make sure that you keep that environment safe. B is the right answer. You want to make sure that you provide for a safe therapeutic milieu. Yes, we want to do all these things, but we know what his history is. We know that he's going to start swearing and he's going to start kicking the furniture in the day room. So it's expected. We know what he's going to do. So we want to make sure that we keep everyone safe. Them.
Oh, okay. I read the question wrong. I'm thinking he's already swearing and kicking, not that he is going to be kicking and swearing and kicking. So, but if he was already doing it, wouldn't you want to de-escalate it?
He is already doing it. So we know what his history is. This is his history. And now he's swearing and kicking in the furniture. We know that this is expected from him because this is what he does. So he's already doing it. So we're not going to, we have to be firm. We have to keep everybody safe. So B is the appropriate answer.
So Mrs. Davis, I'm sorry to continue the discussion. So we're going to provide a safe therapeutic milieu. Can you provide an example of what exactly would be the best thing to do? I mean, are you going to tell everybody to get out of the room? What do you do?
So you have 4 or 5 people there, and we said before, everybody knows their role. So the main nurse that was assigned to taking that care of that patient is going to move closer to that patient, and they're going to start talking to him. James, I can see that you're physically upset. You know this behavior is not acceptable. Everybody else around knows their role. So
right. Wait, I'm sorry. I don't mean to interrupt. Everyone knows their role, but the question's asking what we're doing as the nurse. So what are we doing as the nurse specifically to provide the safe therapeutic environment? Are we then triggering everyone to then participate in their role? Like, I just want to understand exactly like what's expected.
So you would make sure that, yes, that everybody else that knows their role is doing that. So they're talking to other patients, they're signaling them to come over here, they're moving them to other rooms, they're moving furniture, things like that out of the way. They could be used as weapons, stuff like that. Yeah, she's just, yes. Does that help?
We would like somehow, I guess, signal.
Ms. Davis, can I clarify it a little bit better?
Well, Heather, what I want, for testing purposes, what I want you to know is that it is your priority to provide a safe therapeutic milieu. I'm not going to ask you to monitor what everybody else is doing and what should you be doing. I just want you to know that you have to provide a safe environment.
Okay, and that's always the first priority.
Yes.
Okay, got it.
Yep.
Patricia, did you have something to say?
And
I just want to clarify it a little bit better for you to, just to help Heather understand, because I go through it every day. So as the nurse, so I'm a tech, so the patient is destroying the milieu or whatever the case may be, throwing chairs, kicking, yelling. We go in the back, it's called like a meeting. You discuss what's going on before you go out there and take action. So then the nurse will say, you clear the kitchen, you make the call. And then the nurse that's responsible for him will approach him, like Ms. Davis said, and talk him down while we already doing whatever we're doing, if that makes sense. So we discuss it first before you just go right ahead and approach. Like the nurse will say something to everybody.
Right, okay.
Like when she say have your role, the nurse will be like, Trisha, clear the kitchen, such and such, call the code. And while the nurse is approaching the patient at the same time. You get what I'm saying?
Got you. That makes more sense in my head with like a real life scenario. Okay, yeah. Thank you.
You're welcome.
Yes, thank you for your input, Patricia, because you deal with this every day. So thank you for that. All right, a nurse is caring for a patient who is screaming at staff members and other patients. Which of the following is a therapeutic response by the nurse to the patient? Stop screaming and walk outside with me. Why are you so angry and screaming at everyone? You will not get your way by screaming. What was going through your mind when you started screaming?
D.
B.
A, because you want to get them out of the environment.
Oh,
A, because you're being assertive and you want to,
so.
you're telling them what to do.
Oh, B.
You're giving them clear commands.
So the answer is A.
A.
You're being firm. You're not tolerating their behavior that they're exhibiting, and you're trying to take them out of the environment. You're trying to diffuse the situation. Let's go for a walk. We talked about that's a distraction activity. All right. Which of the following is an example of assertive communication? I wish you would stop making me angry. I feel angry when you walk away when I'm talking. You never listen to me when I'm talking. You make me angry when you interrupt me.
B is in baby.
B. Yep. I statement. I feel angry when you walk away when I'm talking. The first one is an I statement, but it's not really saying anything. I wish you would stop making me angry. Well, that doesn't really say what's causing the problem, right? You want to communicate what's causing the problem in a firm manner using those I statements. All right, a patient is pacing in the hallway with clenched fists and a flushed face. He is yelling and swearing. Which phase of the aggression cycle is he in? A, anger, B, triggering, C, escalation, or D, crisis?
Crisis.
D.
C.
D. That's a dog.
C, he is in the escalation phase. He's yelling and he's swearing. You know that things are escalating now. He's not hitting anyone. He's not throwing anyone around, throwing anything around. He has those clenched fists. You know that things are escalating now. So it's the escalation phase.
Okay.
All right. So we are going to talk about abuse and violence. So violent behavior is a national health concern, and it has been a priority for intervention in the United States. Occurrences exceed 2 million a year. Victims of abuse are found across the lifespan. So we have spouses, partners, children, and then elderly adults. Survivors of abuse will suffer long-term emotional trauma, including disorders that are associated with abuse and violence. They can suffer from post-traumatic stress disorder and also from dissociative disorders. So the clinical picture of abuse and violence. So abuse is defined as wrongful use, maltreatment of another person. Perpetrators of abuse are typically someone that the person knows more often than not. Victims of abuse will have, some will have evidence of physical injuries that require medical attention. Evidence of psychological injuries also, so not just physical. They're going to have a broad range of responses. Some of them will be, an example would be post-traumatic stress disorder, anxiety, depression. So abuse is not just physical, it is also psychological. Some clients can be noted to be agitated and visibly upset if they've been abused. Others will present as withdrawn and aloof. Some of them will appear numb or oblivious to their surroundings. Everybody reacts to abuse differently. Domestic violence can remain unclosed for months and even years because victims do not want to get their loved ones in trouble. They're scared of them. Usually the abusers have things holding over their head so that they won't leave, and they fear for their life, that they will probably come back and kill them. So they stay in these situations for a long time. Victims usually suppress their anger and resentment, and they don't tell anyone, not even their closest family members. We see that this is particularly true in cases of childhood sexual abuse. So survivors of abuse often suffer in silence, but they continue to feel ashamed of themselves. They don't have any self-esteem and they feel guilty. When we think about it in the perspective of children being abused, they always, well, not always, but when you talk to them about why they didn't seek help or why didn't they tell someone, they say that they believe that it was their fault, that they did something that they deserved this treatment or that they provoked the person in a certain way. patients that have been, or children that have been abused are more likely to miss school. They are less likely to attend college, and they continue to have problems through their adolescence that also extends into adulthood. Adults feel guilt or shame for not trying to stop the abuse. Survivors report that they usually feel degraded, they feel humiliated, they're embarrassed, they're dehumanized, their self-esteem is extremely low, and they view themselves as unlovable. They believe they're unacceptable to others. They might view themselves as contaminated or ruined. These feelings lead to depression, suicidal behavior, difficulties in your marriage with sexual difficulties as well. All of these issues obviously are going to are not going to allow functional, healthy relationships in their adulthood. So nurses have to be particularly sensitive about the abused client. We have to pay close attention to their need to feel safe, especially if they've been abused and they fear for their life. We have to make sure that they feel secure. And we have to make sure if they've been sexually abused that they know that they're in control of his or her body. And we're going to talk more in detail about these things. One of the things we can do is look at our patient's personal space, maintain a personal space that's comfortable for them. We want to be able to really pay attention and be able to assess their anxiety level. And then if we do have to do some type of physical assessment, we want to make sure that we get permission before touching him. This is even more important in this setting, dealing with these issues, than it would be in just like the med-surg setting. So when we think about family violence, this is when we talk about spouses who have been battered. It can be neglect and physical, emotional, or sexual abuse of children and elders. It can also be considered, we see it in cases where patients are married. And it has to do with marital rape, where one of the patients will make they think that just because they're married, they have to engage in sex, and they have to do what I don't want to say the man, because it's not always the man, it could be the woman too, but whatever the spouse requires of them. Families tend to tolerate abusive and violent behaviors from relatives that they would never accept from strangers. So these are hard issues to confront, and they're hard issues to talk about. And you'll see that sometimes in families that they just get shoved under the rug because they don't want to cause problems in the family. Or if the child's small enough, they think that the child's lying, so they don't pay attention to what the child is saying. Anybody's home should be a safe haven. It should be an area of love and protection, and it should not be dangerous. Family violence is a learned pattern of behavior. It can be perpetuated in generations of families by role modeling and social learning. And your book talks about certain characteristics of violent families. So we will see social isolation. We will see instances where there is abuse of power and control. Sometimes we'll see alcohol or drug abuse, or both. And then we see what's called intergenerational transmission process. And we're going to talk about these. So social isolation. So you'll see family members that keep to themselves. They don't invite other families or friends or family into the home. They don't let anybody know what's going on. They usually threaten their victims with harm if they reveal the secret about what's going on in their home, if they're being physically abused, verbally abused. We see abuse of power and control. So this is where the abusive family member, usually, it's a person who holds a position of power. So a mother, a father, a grandmother, a grandfather. They hold control over the victim. It can be a physical power. So they could be physically abusing them. It can be social control or economic control. So they can be telling them, if you do X, Y, and Z, or if you don't do X, Y, and Z, I'm not going to give you money. You're not going to be able to use your car. I'm not going to give you food.
Right.
It's very common to see that these people will belittle and blame the victim, and they often use threats and emotional manipulation. So some things that we will see, especially with children, is if maybe the father is abusing the child in the home. He might say, if you say anything to your mom, I'll kill your mom. So then the child feels guilty. They're manipulated and they don't wind up saying anything because they don't want anything to happen to their mom. We said there's the possibility for alcohol and or drug use. So the majority of victims of intimate violence report that alcohol was involved. Alcohol may diminish your inhibitions and make violent behavior more intense or more frequent. And then we have intergenerational transmission process. So this is where patterns of violence are perpetuated from one generation to the next by role modeling. So they grow up seeing this, and then social learning. It's what they have learned growing up and they think that it's normal. It's a learned pattern of behavior. Statistics do show that 1/3 of abusive men are likely to have come from violent homes where they witnessed abuse or were abused themselves. Women who grew up in violent homes are 50% more likely to expect or accept violence in their own relationships. So these are important things for you guys to keep in mind. So we have cultural considerations. So we said that domestic violence can span across all ages and all ethnicities, all different types, all the different races, religions, socioeconomic statuses, and sexual orientation backgrounds. It doesn't discriminate, but immigrant women are particularly at risk. So they are more at risk because they have different legal, social, and economic problems than people do in the United States who are battered, and from other people, from other cultural, racial, and ethnic origins who are not battered. So they come from a culture that accepts domestic violence. They believe that they have less access to legal and social services than US citizens do because they're not US citizens. They are afraid that if they seek assistance, that they could be deported, and they face increased legal, social, and economic barriers. So they don't have, sometimes they might just be here by themselves. They don't have a support network, a family that can help them. Because they're not citizens, they might have trouble gathering resources to help leave the person that is abusing them. And then we know that there can also be a language barrier that can interfere with her being able to call 911, or to be able to talk with anyone that they encounter and tell them what's going on with their situation. All right, so intimate partner violence. So the definition is the mistreatment, misuse, or abuse of one person by another in context of a close, personal, or a committed relationship. So this is spousal, can be between partners, so they're not married, boyfriend, girlfriend, girlfriend, or even in an estranged relationship. So we can have emotional or psychological, and we can also have physical. So emotional and psychological, this is name calling. Somebody's belittling someone else. They're screaming and yelling. They could be destroying property, threatening the person, refusing to speak to them, or ignoring them. Those are emotional or psychological forms of abuse. Physical would be shoving, pushing, battering, choking, any kind of battery that can result in broken limbs, ribs, brain damage, internal bleeding, and homicide. So just some statistics. Usually what studies show is that the abuser has multiple types of abuse. So it could be physical and emotional. Usually they have multiple components. Pregnant women suffer from an increase in violence during pregnancy. It can result from the partner being jealous because they're not the center of attention anymore. Now the mom is focused on the baby and having a healthy pregnancy, and she's excited for the baby to come. If they're jealous, they also may feel insecure. They're possessive over their wife. They don't want anything that's going to jeopardize the love that they have for them. And then they have lessened physical and emotional confrontations with the patient. These lead to adverse outcomes. So if it results in physical abuse, then there could be a miscarriage or a stillbirth. as well as further physical and psychological problems for women. We also have a prevalence in same-sex relationships, as in heterosexual relationships, but what studies show is that victims have fewer protections. And then intimate partner violence can exist with former partners as well. So just because they've broken up and they're not together anymore does not mean that they're still not able to abuse them emotionally or physically. So when we paint that clinical picture of what that partner violence looks like, so the abuser's view of the wife, they believe that that the wife belongs to them. It's his property. They own that person. The abuser typically has strong feelings of inadequacy. They don't have self-esteem. They don't have good problem-solving skills or good social skills. Studies show that they're emotionally immature and that they're irrationally jealous. We even see that sometimes they're jealous of their wife's attention to their children, and they might beat the children and their wife together because they see the children as a threat to him. They're needy and they're possessive. Like I said, they believe that the partner is their property. Sometimes we see that violence increases when the wife exhibits any type of independence. So if they say, I want to get a job outside of the house, that's very threatening to them because they're afraid if they leave the house, then they might realize that they're being treated poorly and that they might take the advice of someone else and they might leave the person. Or if they get a job, they won't be as dependent on them anymore. So some people use that as control. If they don't have a job, they're going to need them and they're going to be able to treat them however they want because they're under their control. Abusers often experience a sense of power and control when they're bullying their loved ones and abusing them. They almost see it as a rewarding behavior. When they're violent, it's rewarding and it helps to boost their self-esteem. Victims are commonly dependent and viewed as unable to function without the husband because that's what's been instilled in their brain. And most of them aren't allowed to work or they don't work and they don't feel like they even are estranged from their family members in some cases. So they don't feel like there's ever an option for them to be without their husband. So they're kind of stuck in this situation. And then women obviously fear that the abuser will find them and kill them if they try to leave because this is probably what they've been told. And national statistics show that there's a 75% greater chance of these women being murdered when they leave an abusive relationship than those who stay. That's a big number. So intimate partner violence is a cycle of abuse and violence. So you have this violent episode followed by this honeymoon phase, then this tension building phase, and then this violent episode. It's a vicious cycle. So initially, they have this honeymoon phase. It can last for weeks or even months. The woman believes that their relationship has improved. The husband's behavior has changed. Things are going to be great. Over time, the violent episodes start again. They become more frequent. The period of the husband being remorseful disappears altogether, and the level of violence and the severity of injuries increases and worsens. Eventually, the violence becomes an everyday routine. It can be several times a week or even daily. The majority of abused women do not seek direct help. We talked about why those reasons are, mainly because of fear. As nurses, we must make sure that we can identify abused women in a variety of different settings depending on where we work. So we can see these people in the ER, we can see them in outpatient clinics, in pediatrician offices. Victims may come in and they are seeking treatment for other medical conditions not related to the abuse, or if they're pregnant, for their pregnancy, but there may be things that you recognize that are not normal. Identifying abused women who need assistance is the top priority of the Department of Health and Human Services. So most facilities have a screening assessment that you do. It's called SAFE. So you are looking to see, is the patient stressed? Do they appear stressed? Do they feel like they're not safe? What kind of, are they acting funny around their husband? Do they have a lot of bruises? Are they not allowed to talk? Does the husband talk? Do they not have any friends or family? I mean, all this would vary depending on the setting that you saw them in. And then we would want to talk to them if we believe that there was something that was going on. We would want to know if they have an emergency plan in case someone was trying to hurt them. So some common questions that we could ask about safety. So do you feel safe in your relationships? Are you concerned for your safety? Are family or friends concerned for your safety? Do you feel like your children, if you have any, are safe? Do you ever feel threatened? If you feel threatened or unsafe, is there someone you can call day or night? Do you have a safe place to go to if you need to? And do you have a plan if your situation suddenly becomes unsafe? And you can look at table 12.1 in your book. It goes over these. So this is a list of the do's and don'ts of working with victims and partner abuse. I'm going to let you read all of these because there's a lot of them there. So communication strategies. So we can use these as guiding principles for when we are screening patients for potential abuse. So we need to have an attitude of approachability. So we need to know and be confident that we can approach our patients if we suspect that something is happening. And we need to have that attitude. We need to know that it's our obligation to approach these people, look for these issues, and make sure that they're safe. We have to believe in the woman's account of her own experience of abuse. If she tells us that this is what happened, we have to believe her. We have to make sure that we are always maintain confidentiality, unless, of course, there is a child or an elder involved, then we're obligated to contact other people. We always want to make sure that we're documenting what the patient says and what we see. If it's in the computer, we just want to make sure either way that it's consistent. And if it's on paper, we want to make sure that it's legible so that anybody else that comes around us will be able to understand what we've written. We want to encourage the patient to talk about their feelings related to the abuse, and we want them to feel like that we're accepting and that we're non-judgmental. It can be very hard to get these people to talk. We can't make them talk. We can only encourage them to talk. So just letting them know that you're there for them, really be present with them, listen when they talk. And we can also educate them about the serious effects of abuse. Most places have pamphlets. If they don't have pamphlets, there's usually something on the computer that you can print out and give to patients. So even if they're not willing to talk, at least they know what the serious outcomes can be, and it's something that they can think about. And then ultimately, we have to have respect for the integrity and the authority of each woman's life choices. So for some of us, it might be very black and white. You know, if somebody hit you or I, we might ultimately know 100% that we would never stay with that person. We would pack our children and we would leave. It's not like that for other people. Other people don't have resources. They don't have family members. They may live in this state alone, or they might be terrified of their husband. So if they decide not to talk, or if they decide to go back home with the husband, we have to make sure that we don't let that change the way we think about our patient. We still need to have respect for them and their decision. And then we have to have recognition that the process of dealing with identified abuse must be done at that patient's pace and by their own decisions. It's not something we can force them to do. So what are the treatments and interventions? Well, there are obviously laws that are related to domestic violence. Obviously, the person can be arrested, they could go to jail. There are restraining orders and civil orders of protection. So restraining orders legally prohibit the abuser from approaching or contacting the patient. However, these restraining orders only offer limited protection. And just because they have it doesn't mean that the abuser will abide by it. They can decide to violate the order and severely injure or kill the patient before police can intervene. So that's something to think about. Civil orders of protection are more effective in preventing future violence when they are linked with other interventions. So if someone is, if they are not allowed to go around their loved one because they did X, Y, and Z, then we have to make sure that they get counseling, the person who is doing the violence. And then for the person who was the victim of violence, we want to make sure that they also can receive counseling. If they can't go back to the home anymore, or if they left the husband, we want to make sure that her and her family, maybe her children, they have shelter to go to, a nice, safe place to stay until they can get back on their feet. Shelters can provide temporary housing and food for abused women and their children when they decide to leave abusive relationships. But the downside is that they're overcrowded. There's not a lot of resources. Some of them don't have any availability. There's long waiting lists. And even if they do get in there, it's temporary because the need is so great that they have to, people can only stay for a certain amount of time. These patients may not have any financial support, and they might have limited job skills or experiences. Maybe they've got married when they were 18 and they've always just been a wife and a mom. So maybe they've never even worked outside of the house. More often than not, the victim has dependent children. So these barriers, you have to understand, are going to be very difficult for the patient to overcome. So no financial support. If they don't have any family members here, if they don't have any skills, they may not, and if the private and public assistance is limited, they might not feel like they even can leave the abusive person, that their only option is to just stay there. We know the importance of individual psychotherapy, counseling, there's group therapy, self-help groups. We know that the effects of abuse, that there's going to be emotional and psychological consequences, long-term consequences. So these patients need to have this ongoing therapy. It can help women deal with their trauma. It can help them learn from other people that have been in the same situation. They can be a good source of help for each other. It can open up doors for resources that other women used that can help these women. It can help them build healthy new relationships and a network of people that they can depend on. We know that sometimes when patients are victims, it can cause anxiety in treatment. So we want to encourage that they see a therapist, and if required, that they take medication that would help them. And then statistics show that women who left their abusive relationships are more likely to be successful if their legal and psychological needs are addressed simultaneously. So it's important that once they make that decision to leave, that we make sure that if we can, we give them all of the support that they need to be successful. So some nursing diagnosis that we may see: anxiety related to threat of self-concept, situational crisis abuse, impaired verbal communication related to psychological barriers of fear, powerlessness related to lifestyle of helplessness, post-trauma syndrome related to history of abuse, insomnia related to psychological stress. All right, a charge nurse is leading a peer group discussion about family and community violence. Which of the following statements by a family member of the group indicates an understanding of teaching? A, children older than 3 are at a greater risk of abuse. B, substance abuse disorder does not increase the risk for violence. C, entering an intimate relationship increases the risk for violence. Or D, pregnancy increases the risk for violence towards the intimate partner.
D.
D.
D. Yep, the answer is D. Pregnancy increases the risk of violence. All right, so now we're going to talk about child abuse. So child abuse is just that, the intentional injury of a child. So we can see physical abuse or injuries. So these are these injuries can result from unreasonable or severe punishment or unjustified punishment. So hitting an infant for crying or soiling his or her diaper. Obviously, that is not justifiable. Children cannot, that's the only way of communicating for an infant. And that's a common finding that we would see in a child. We would expect them to soil their diaper. So unjustifiable punishments. We can see biting, burning, cutting, poking, twisting of the limbs, scalding children with hot water. Our abused children usually have evidence of old injuries, so they might present with scars or untreated fractures or multiple bruises, which that can be hard with children because we know that some children are just clumsy, and when they're little at a certain age, they're running around and they're running into everything. But bruises on the back, bruises in certain places on the body and the face, things like that, these are things you want to look at. And if we see multiple bruises in various places, and then when we talk to the parents and their caregivers, if they can't come up with an adequate explanation or one that fits the bruises, then that's when we want to try and say something doesn't seem right here. We can also see sexual abuse of children. So this involves sexual acts performed by an adult on a child younger than 18 years old. So some examples we see is incest, so between family members. We see rape, sodomy, which is performed directly by the person or with an object. It can be oral genital contact. It can be acts of molestation, such as just rubbing, fondling, or exposing the adult's genitals. Sexual abuse can be just a single-handed incident. It happens once, it never happens again, or it could be multiple episodes over a period of months, even years. A second type of sexual abuse that we see is what we call exploitation. So this is the making, promoting, or selling of pornography that involves minors and the coercion of minors to participate in obscene acts. We can see neglect. Neglect is a malicious or an ignorant withholding of physical, emotional, or educational necessities that are needed for the child's well-being. The most prevalent types of maltreatment that we see are parents that refuse to seek health care for their children, or they delay doing it. Parents that abandon their children if they don't adequately supervise their children. So they go to bed and they leave the 2-year-old up, and the 2-year-old runs around the streets, and the neighbors find the kid running around with no diaper on. Inadequate supervision, reckless disregard for the child's safety, punitive, exploitive, or abusive emotional treatment. Even abusing the spouse in front of the child is considered neglect. Giving the child permission to be truant so they don't have to go to school, and then failing to enroll the child in school. Then we have psychological abuse, which is also called emotional abuse. So these are your verbal assaults. This is when we're blaming them for things, we're screaming at them, we call them names, or we talk to them using sarcasm that humiliates them. We see this in families who are constantly fighting, yelling, and live in an environment where there's nothing but chaos. Emotional deprivation or withholding of affection or not nurturing your children. Normal experiences that engender acceptance, love, security, and self-worth. Emotional abuse often accompanies other types of abuse. So it's usually you just don't see that they're emotionally abusing them. Usually there's sexual abuse and physical abuse as well. And we can also see psychological abuse when these children are exposed to parents who suffer from alcoholism or drug abuse or even prostitution. So what is the clinical picture of parents that are abusive to their children? So we see that these parents have minimal parenting knowledge or skills. They don't understand or they don't know what their children need. They might get angry or frustrated because they know that they're incompetent and then they're not meeting their children's needs. It might be upsetting that they financially can't meet their needs. They're emotionally immature, so they're really incapable of really taking care of themselves, and they definitely are not mature enough to take care of a child. Some people view their children as property. They don't value their children as people with rights and feelings. And then we do see this cycle of family violence. So adults raising children in the same way that they were raised. Adults as victims of abuse frequently abuse their own children. And even not just abuse, but if you were raised a certain way, if you got paddled, we see that adults, when they have children, they do the same thing because that's what they view as normal. I know myself, when I was being raised by my mom, she never let me have a voice. I was never allowed to speak about how I felt. It was her way or the highway. If the sky was black, but it was really blue, I would never say anything. And I wound up doing that same thing with my children. Even though I said I was never going to be anything like my mother, I did see myself doing those things. And my children were able to point it out to me, and I worked hard not to do it anymore. But these are things that happen because it's how we were raised and it's what we saw as normal. So we do have to be conscious about it. Let's see. Oh, okay. So we have to be able to recognize suspected child abuse, depending on what setting we work in. There's different warning signs on page 193, box 12.3 in your book. We want to be able to recognize when a child's behavior is outside of what we would normally consider, what we would consider normal for that age or their developmental stage. So if we see patients that come in that have urinary tract infections, when we go to look at them, if they have bruised, red, or swollen genitalia, or if they have tears of the rectum or vagina, or any type of bruising in that area, we know that this is not normal. So this could be a sign of sexual abuse. We want to pay attention to odd behaviors. So if patients refuse to eat, or if they're having aggressive behaviors at daycare with other children, these are things that would signal something might be going on. Let's look into their home life, what's going on. And then, of course, we are obligated to report suspected child abuse. We want to make sure that we document all of our information accurately and thoroughly. All 50 states have laws that are called mandatory reporting laws, and they require nurses to report suspected abuse. So we do have that obligation. So treatment and intervention. So we always want to make sure that the child safety is our priority. We want to think about their emotional well-being, their physical safety. Sometimes keeping them safe and protecting their well-being means that we have to remove them from the home, which can also be traumatic. We have to remember that these children you will see, and children that are abused sometimes love their family members more than others do, regardless of how they're treated. So just because they're being abused, we know we're doing the right thing. They don't know that, and they don't see it that way, and they don't want to be away from their family members. So this can cause a whole nother set of traumatic issues. We want to make sure that they get a psychiatric evaluation right away. Children who are abused definitely need psychiatric help, possibly even long-term therapy, depending on the extent of the abuse. Usually with children, we do play therapy for very young people because it's hard for them to put into words what happened and because of the extent of the abuse. So therapists can have them play with dolls or puppets, and then they can actually have them draw things out or act things out. So that's a good way to get younger children to talk. And then just like any other nurse-patient relationship, there has to be a relationship of trust between the therapist and the child because we want the child to be able to deal with that trauma of abuse. So they have to feel like they're safe. Family therapy can happen if they're going to be reunited with their family members. If the abuse was so extensive that they won't be going back to the family, or if maybe the parents have given up their rights to the child, then they wouldn't have family therapy. But if it's feasible for them to go back, then they will encourage the mom and the dad or whoever's in that family to meet on a weekly basis with the therapist and the child, so that way things will be better for the child when they return back to the family members. And then we want to offer psychiatric or substance abuse for the parents who are abusing their children. So nursing diagnoses that we may see: uninterrupted family processes related to inadequate coping skills, fear related to threat of punishment or perceived wrongdoing, acute pain related to physical injuries, post-traumatic stress syndrome related to physical abuse, incest, rape, or molestation. And then social isolation, family imposed, related to fear of disclosure of family dysfunction and abuse. All right, so elder abuse. This is the maltreatment of older adults. So this can happen by family members or care providers. It can be physical, it can be sexual, psychological, or neglect. It can also be self-neglect. They're not taking care of themselves. It can be financial exploitation, where people neglect them and take their money from them. And it can be the denial of adequate medical treatment. So if they have a care provider or a family member who's taking care of them and they don't recognize issues that are going on, or if they're just overwhelmed and they don't seek treatment for issues that they can see. So if they have a cold or if they have some type of an infection. 60% of the perpetrators are spouses, 20% are adult children, and 20% are others, so family members or care providers. We see elder abuse is more likely to occur when the patient has multiple chronic mental and physical health problems, and when he or she is dependent on others for food, medical, and various activities of daily life. So it can be very hard for loved ones or care providers to care for people that have multiple mental and physical health problems. It's not an excuse to mistreat them and abuse them, but sometimes it happens on an unconscious level. So it's still considered neglect, but it happens when the patients are overwhelmed and they don't, or they're not adequately educated about taking care of the patient. And because these people are dependent on them, it becomes easy for them to manipulate them and treat them terrible because they have no other choice but to deal with what's coming their way, because if they are dependent on their loved one for food and activities of daily living, then they can't really go anywhere to seek any kind of help. So people who usually abuse them are almost always the caretaker or the elders dependent on them in some way. Most cases occur when an older spouse is taking care of another spouse. Usually happens over many years after a disability renders the abused spouse unable to care for himself or herself. Elders are often very reluctant to report any abuse when they come into the hospital or to the primary care setting because their children have told them that they'll put them in nursing homes or that they will not take care of them anymore, and they're afraid of leaving their family members. So just like all the other issues that we talked about tonight, we need to have a clinical picture of what it might look like if we saw someone who was suffering from elder abuse. So we might see bruises, we might see fractures. These are two common things that we can see in older adults. We know that their bones are not as good as they used to be. They're at a higher risk for developing fractures, and we know that they lose a lot of their subcutaneous fat. So we know that they bruise very easily. So we have to, if we see those things, we kind of have to make sure that we ask questions and put it in context to the whole situation. If patients say that they're denied eyeglasses or hearing aids, or if they're not getting food or their medication, if we think they're being restrained in a bed or a chair, or if they're being left in a bed or a chair and they're not ever being turned, or they're not being given the opportunity to be mobile. So getting into a wheelchair, coming out into the living room with other family members. Some abusers will continue to keep these patients at home and say that they're taking care of them because they want their monthly income, so their Social Security or their pension. And what will happen is they'll take their financial resources, and then the patient still doesn't have what they need. So they don't get their food, they don't get their medications, but their loved one won't put them in a home because they need their money. We see this, I've seen this a couple times at work. This absolutely happens. So it is very important that we do that good assessment of our elderly patients when they come in, and the interactions with their caregivers or their family members, because we want to always be on the lookout for detecting elder abuse. There are potential indicators that would require further assessment, and you can read about them in box 12.4 of your book. And there is something called the ombudsman. So in 1978, the federal government mandated it, that it was acceptable for these ombudsmen to visit nursing homes to check on the care of the elderly, because we know that there's a high susceptibility of elder abuse. And what they do is they go to these facilities, they check on these patients, and then they report back to the government any complaints of elder abuse in these situations. So treatment and intervention. So one of the things we talked about was, we said that sometimes the caregivers may neglect their patient, may neglect their loved ones, but it might not be intentional. It can be a big burden to care for these patients. They might not have the education to properly care for them. They might not have the resources to properly care for them. Maybe they're trying to do the best they can. Maybe they have to work and they have a caregiver that's coming in and a caregiver isn't taking care of them. So we want to look at the caregiver and assess for any type of stress. If there is any kind of stress there, we want to offer them some type of relief. Sometimes we can do something called respite care, where they can go, it's kind of like a nursing home, and they can go there for a week or two, and it kind of gives the caregiver or the family members an opportunity just to relax and catch up and breathe a little. Or maybe if they want to take a vacation, maybe they haven't had a vacation for a couple years, they can go with their family and have a vacation and know that their loved one is being taken care of. So that's respite care. We know that abuse will develop gradually as the burden of care exceeds that person's physical or emotional resource. And some people don't want to put their families in nursing homes, and they believe that they're taking care of them. And they feel guilt about putting them in a nursing home, so they just do the minimum they can to try and keep them at home. Some cases we have to remove the elder or the caregiver from the situation. If it's intentional, we remove the elder, and then we have to go to court to decide where the patient will go. It's ultimately designed to provide, we see these in cases where the caregiver is just taking care of the patient so that they can have access to the victim's financial resources. In these situations, you're always going to see that if they discover that that's the case, that the elder is removed from the environment. Okay, so rape and sexual assault. So rape is the perpetration of an act of sexual intercourse with a person against his or her will and without her consent, whether that will is overcome by force, fear of force, drugs, or intoxicants. It is considered a crime of violence. It is a humiliating act for the victim. The definition of sexual assault is pressured or forced sexual content, including stimulated talk or actions. It can be inappropriate touching or intercourse. It can be incest, even human trafficking, mutilation of female genitalia, and then of course rape, which is that forced sexual penetration. It is also considered rape if a woman is not capable of exercising her rational judgment because she has a mental deficiency, some type of intellectual developmental issue, or if they're younger than the age of consent. Only slight penetration of the vulva is needed. There does not have to be a full erection or ejaculation necessary in order for it to be considered rape. When we think about forced acts of oral sex and anal penetration, although they frequently accompany rape, they are actually legally considered sodomy, which is still considered a sexual assault. And the person who is raped may also be physically beaten and injured. And then also there's emotional assault, obviously, that goes with that as well. So 25% of the rapes happen at the hands of strangers. It can be acquaintances, it can be married people, people of the same sex, and then we can also have date rape. We also call it acquaintance rape. Sometimes people will go to a party and they'll leave their drink out. They'll put some type of medication in their drug. I mean, some type of drug in their drink. They'll drink it and then they don't remember what happens. And then they wake up somewhere and they might not be clothed, or they might have the impression that something happened. So that would be date rape. It can occur on a ride home from a party or when two people have known each other for some time. So it doesn't have to be someone that you just met and it was like a blind date. More often than not, they do know the person who does it. We do see that this issue is more prevalent on college campuses, and rape is a highly underreported crime for a lot of obvious reasons. Studies show that less than 1/2 of all rapes are reported. And this is usually because the victim feels guilty, they're shameful, they're embarrassed, they don't want their family members to know. They're afraid of retaliation. They're afraid that the person that did it is going to retaliate and do it again or do something worse. And they also believe that the legal system will not be there to help them, or they don't want to go through the process that they have to go through in the legal system, because they have to reiterate, they have to keep telling the story over and over again, and then they'll have to go to court, and they don't want to do that. It's humiliating. And it's kind of like reopening an old sore over and over again. They just want to put it behind them. They do say that most of these crimes occur in a woman's neighborhood, often inside or near their home. Most rapes are premeditated, and then male rape is significantly underreported. Male rape is something that is more prevalent in institutions such as prisons, and it's estimated that over 80,000 male inmates are sexually assaulted each year. And then about 34% of all rape cases, there is alcohol involved. So there are 4 categories of male rapists. When they put these into categories, it was described in terms of motivation or dynamics. So it's not a sexual crime, but it's an exertion of power and control. So we have the power assertive rapist. We see this in 30%. So this is someone who's trying to assert their power. They're trying to have control. Power reassurance or an opportunity rapist. So this is when the opportunity presents themselves and they want to reassure themselves that they're still in power and that they can still have control. An anger retaliation rapist is they might not be angry at that person, but it could be another female that looks similar to them. Maybe they were involved in a relationship with someone and that person broke up with them, or it was their wife and now they're divorced and they're retaliating against that person by raping another person that looks similar to them. And then we have anger, excitement, or a sadistic rapist. So this is just the person who enjoys hurting other people and they find it exciting. So obviously, rape and sexual assault can cause severe physical and psychological trauma. The level of violence experienced during the assault is a very predictive indicator of the amount of medical services that people will require in the future. So that's primary care visits, visits to the ER, crisis episodes, mental health issues across the board. These patients have a lot of fear. They feel very helpless. They might be in shock. They have a lot of disbelief that it happened to them. How could it happen to them? Then they start to wonder, what did they do? They certainly somehow, some way must have asked for it. So then they start replaying in their mind, well, what did I say? How did I dress? Did I make them feel like I wanted to have sex with them? What did I do wrong? And then they start feeling humiliated. They're embarrassed. They don't want family members or friends to know. So it's very common for them to avoid places or circumstances of the rape. So if it happened at a bar or around a bar on a night where she frequently went with her friends, she might avoid that place or that area altogether. Sometimes it results in a loss of previously pleasurable activities. And usually we see this because it's associated with depression. These patients can have a lot of anxiety. They can have post-traumatic stress disorder. They can have sexual dysfunction in future relationships. They can have trouble sleeping. Their memory, sometimes they don't have a lot of memory about what happened with the incident. As time goes by, they forget it, and that is troubling to them as well. Some patients have suicidal thoughts because they can't live with the guilt and the fear and the embarrassment that they have, so they don't want to live. And then it also causes issues with trust and future relationships. Until recently, it is true that the rights of rape victims were often ignored. There was, especially from police officers, there was a big stigma regarding the embarrassing questions that they asked, and that some police officers made these victims feel like they were lying. And then courts at that back, and just even a couple years back, didn't protect the victims' rights. So it was very common that a woman's past sexual history or their behavior could be admissible in court as evidence, but they weren't allowed to bring up the past criminal record of the accuser, even when that past criminal record included rape. We don't really see that too much anymore. This was years back. So these are some common myths about rape. So rape is about having sex. That's not true. When a woman submits to rape, she really wants it to happen. Women who dress provocatively are asking for rape. Some women like rough sex, but later call it rape. Once a man is aroused by a woman, he cannot stop his actions. Walking alone at night is an invitation for rape. Rape cannot happen between persons who are married. Rape is exciting for some women. Rape occurs only between heterosexual couples. That's not true. We see it across the board. If a woman has an orgasm, it can't be rape. Rape usually happens between strangers. More often than not, that is not the case. Rape is a crime of passion, and rape happens spontaneously. All right, so when we do our physical assessment, what are we going to look for? So one of the most important things is that we want to preserve any evidence that the patient may have. So usually we do what's called a rape kit. It is part of what a hospital would consider a rape protocol. This is always performed by the physician or a specially trained sexual assault nurse examiner. They usually are responsible for doing this. So they know how to handle the evidence. So we want to try to do this. Hopefully the patient has come within a certain number of hours. After she's gone home and she's taken her clothes off and she's washed them and she's showered, there's not a lot we can do. So we ideally would like to have this physical examination before the patient showers, before they brush their teeth. We're going to want to take mouth swabs before they douche, before they change their clothes or have anything to drink. But like I said, this is not always ideal. The amount of people that present to the emergency room like this are few and far between. Usually they've gone home because they don't want to talk about it. They're embarrassed. They just want to shower. They want to scrub away all the disgust that they feel. They throw their clothes away or they wash them right away because they want to stop thinking about it. And then when we talk to the patient, we want to have a description of what happened. So we have to understand that these conversations are very hard, and it's not going to be easy for the patient to talk about something that's so vulnerable. We want to make sure that when we question them, that we question them gently. We want to practice empathy. We want to provide them enough time to answer, and we want to let them know that we care. So we don't want to pass on any judgmental attitudes. We don't want to have any questioning behaviors. And then, of course, we will always follow our facility's policy and procedures for reporting abuse. So we know that these patients are going to need immediate support. We want them to know that they can express fear and rage to us, the nurses, to the physicians that they talk to the law enforcement officers who come in, and to their family members who believe them. We want them to know that we believe them, and we want to encourage that communication. We don't want them to keep it bottled up. We want to give them as much control as possible to the victim. So ways that we can do this, because they don't feel like they have a lot of control because of what happened. So We can let them make their own decisions when at all possible. So when do you want to talk about this? Who do you want to call? Who do you want to have in the room with you? What do you want to do next? Try and give them as much control as we possibly can. We can be an advocate for the patient and make sure that they have a counselor or a volunteer to be with that victim in the hospital throughout their process after discharge. So this person would be their personal advocate that would come and advocate specifically for their needs. They're totally available for the victim. They're just assigned to that person. And then after their discharge, they would follow them into the community and continue to advocate for them. So setting up self-help classes, going to these classes with them, really showing up for them and being supportive. Understanding that providing this unconditional support is going to be crucial to their recovery. They need a lot of support. We also want to educate them. So we want to educate staff members, healthcare professionals, law enforcement officers, and just the general public about rape and the needs of the victims, because it's so crucial that we provide that support for them. So it's ongoing learning for all of the healthcare professionals. We will also offer prophylactic treatment of STDs and pregnancy. So because of the cost, many victims will not return to get definitive test results for their diseases. They don't want to accrue any bills. They don't want to have to deal with any bills because it's going to make them think about the situation. And once they leave, they don't want to think about it anymore. So we want to make sure that when they're in the hospital, we can get them to consent to as many tests as possible, and then give them those results before they leave. We definitely want to encourage HIV testing when they're at the hospital, but we also want to educate them about the fact that the test can come back negative when it really is positive. So we have to encourage them to be tested at specific intervals. And then we can always do prophylaxis, these medications to avoid any pregnancy that could have occurred as a result of the rape. So any therapy that we do is to help restore the victim's sense of control. So we always want to make sure that we are reiterating to the patient that we are here for them and that we are supporting them. That is our goal, is to support them in any decisions that they make. We want to focus on restoring their sense of control. So giving them ways to exercise control in the situation in the hospital, whatever they can, however you can. We want to listen to them and talk to them and help relieve those feelings of helplessness. We want to talk about dependency. Some patients will become very dependent on other people because they feel like they're helpless now. So we want to encourage them to be more dependent and take on the activities that they normally took on before this assault occurred. Sometimes they have the obsession with the assault that follows the rape. So they're going to need a lot of counseling afterwards, because we know that obsession can turn into, an unhealthy obsession, and that can manifest in a number of ways. They should be in therapy working on regaining trust, because obviously they don't have a lot of trust right now because of what has happened. And we know that not everybody that they meet is going to hurt them and do this to them. So we want them to ultimately have a goal of being able to regain trust somewhere down the road. We want to see that their daily functioning is improving. They're getting up every day. They're getting a shower. They're getting dressed. They're talking to family members. Maybe they're starting to meet up with friends again. They're taking a liking to things that they used to like before. Maybe they used to bike ride all the time, but then they stopped, but now they're starting to do that again. So signs that they're improving. We want to make sure that they can find adequate self-support. So making sure they have that advocate that can follow them into the community setting. And then we want to make sure that they have therapy that will help them deal with feelings of guilt, shame, and anger, because there's a lot of different components to this, just like grieving. They go through different periods. So, they're embarrassed, and then they feel guilty. They think that they've done it, and then they're ashamed of themselves. And then they start to realize that it wasn't anything they did, and then they're angry. and then they start to obsess over it. So there is a pattern there. All right, school violence. So this includes homicides, suicides, theft, and violent crimes. Less than 3% of murders in schools happen by homicide. It seems a lot worse, I think, because we hear so much about it on the news, but it's actually less than 3%. Multiple homicides by a single shooter are more common than one-on-one homicide at schools. We also see bullying. We know that bullying is correlated with an increased risk of suicide. We can see verbal aggression, physical acts to other people that involve shoving them, hitting them, breaking their bones. We know that students can be targeted or shunned or ignored by others. There can also be cyberbullying. So this could be where the person is getting unwanted emails, text messages, or pictures posted on the internet. And the internet is such an easy way to abuse people because there's no accountability. They can just send off an email and they can, half the time their parents don't even know what's going on. The frequency of bullying we see is the highest between children in 6th grade through 8th grade. And when studies on children that were bullied, they reported that they felt more loneliness, that they had a lot of difficulty making friends, and that poor grades and the increased use of alcohol and tobacco were associated and to be more likely in children who had been bullied. So hazing is something you guys have probably heard about. Usually it's prominent in your athletic teams, your college fraternities, certain groups that offer some kind of special status or prestige. We see it as a way of them initiating themselves into certain clubs. They have to do something that they decide usually is something very risky or off the wall that endangers their life. But if they do it, then they're initiated into this club. And then they have this sense of belonging. We see this most prevalent in high school and college, and it's where these patients partake in humiliating acts, a lot of alcohol consumption, isolation, and sleep deprivation. So what is the effect of community violence on children and young adults? So when children witness violence, we know that they're going to experience stress-related symptoms according to the amount of violence that they see. So they can have insomnia, they can have anxiety, they can have depression, they can develop social isolation. And the degree of which they see these will obviously depend on how bad the violence was that they saw. When they witness violence, it can also lead to the development of future problems with aggression, depression, anxiety, social isolation, developing healthy relationships, achievement, and then also the abuse of drugs and alcohol because they don't have those coping skills. And then we know that there's always the possibility that these children will end up contributing acts of violence themselves because this is something that they saw as children. So when we talk about violence on a larger scale, so terrorism, we know that it affects all the citizens in the United States. It's a large amount of people that it affects. Just like 9/11, if we talk about that, we know that children were afraid to go back to school, or they didn't want to be away from their parents. Parents didn't want to leave their children. They didn't want to go back to work. Adults that didn't have children didn't want to go back to work. They wanted to stay at home. They had fear of using public transportation and then flying. So it has a huge effect on our society. And then we know that with anything, early intervention is the best for the best possible outcomes for our victims. All right, so the nursing process. So what are we going to look for when we're doing our assessment? So we're going to look for a history of any trauma or abuse. So this would require us to ask a lot of questions. If they're in a primary care setting, we probably have access to their file. We would be able to see it, probably not so much in the hospital setting if they haven't been there before. We want to pay attention to their general appearance. So how do they look? Do they look like they have been abused? Do they have bruises, broken limbs? Are they afraid? What is their motor behavior? Are they hyper alert? Are they anxious? Are they agitated? What type of a mood are they in? What is their affect? What is their thought processes? So are they having nightmares? Are they having PTSD and they're having flashback? Do they have destructive thoughts, or are they very impulsive? So these are all things that we would want to look at. All right, so when we're assessing adults for abuse, the role of the nurse is to make sure that we ask questions in a gentle, caring way. If the patient does admit that there's something going on, then we have to acknowledge the abuse. Even if we don't, even say maybe it happened 3 months ago and there's no physical signs that you're seeing right now and the patient emotionally appears to be fine, you still want to acknowledge the abuse and listen to what the patient has to say. You're going to support the patient, you're going to validate their feelings and that experience, and you're going to practice empathy with them. So you're going to say things like, that must have been very terrifying. It sounds like you were afraid for your life. These are all comforting, supportive ways to let your patient know that you're listening and that you empathize with them. You want to also assess any kind of immediate safety issues. So do you feel safe now? Is there someone at home that is hurting you? Do you feel safe going home? So asking all those questions that we talked about a couple slides back. So you can explore different options. And by doing this, you're going to engage the person in the process. So you can talk to them, especially with the spousal abuse. We know that sometimes they feel like they can't leave and they don't want to take that step, especially if they have children, because they can't support themselves or their children. And ultimately, the decision is up to that person. But we can talk about the different options that are available. And by giving them different options, they will hopefully engage with you, start to ask more questions, and then you can start to ask more questions, and it'll open up that door for that discussion. And these are hard conversations. So you have to remember that. Hard for the patient and then hard for the nurse. It's not easy to hear that these things happen to people. It can be very upsetting. And then we want to refer to violence against women services, obviously, if the woman wants it. If they don't, we can't make those calls. We can't force the patient to do anything that they're not comfortable doing. And then always, 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 we're going to document any interaction with the patient. In our documentation system. So some nursing diagnosis that we may see: chronic sorrow related to forced loss of virginity, risk for post-traumatic stress syndrome, trauma or violence associated with rape, risk for chronic low self-esteem, risk factors: perceived lack of respect from others, feeling violated, risk for powerlessness, risk factor inability to control thoughts about the incident, and then ineffective coping related to inadequate confidence in the ability to deal with a situation. So what outcomes would we expect to see? Well, we know that the patient will be physically safe. They're not going to be around anyone who's going to harm them or hurt them. The patient will be able to distinguish between self-harm ideas and actually taking action on those ideas. They will learn healthy ways to deal with stress. They're going to be able to express their emotions non-destructively. And then they're going to establish a social support network in the community that can help support their needs. All right, so interventions that we want to do are to promote patients' safety. So if we think that the patient is being abused by someone, then we want to talk to them about what their options are. Give them all the education that they need to make a good decision. Let them know that they're supported. Let them know that what's happening to them is wrong. We want to help patients cope with stress and their emotion using various techniques. We want to help promote the patient's self-esteem, because a lot of these issues that we talked about tonight can affect a person's self-esteem. So we want to let them know that these conditions don't define them. Very early on, these conversations probably are not going to be helpful. After they seek help and they've been involved in therapy for some time, then they are going to start to recognize and gain more self-esteem. And then we want to help establish social support. So getting in touch with those rape crisis centers, getting in touch with those community advocacy groups that they can go to meetings and be around other people who have experienced the same things, and then any other local resources. So what would our evaluations be? So like I said, these outcomes could take months, they could take years, depending on the severity of the violence and how long it happened to the patient. Studies do say that it often takes a year or more for survivors of rape to regain previous levels of functioning. So they can be very debilitating. A lot can happen in this year. We want to offer protection of self. We want to be able to manage stress and emotions, and we want them to be able to function ultimately in everyday life prior to the abuse. So some self-awarenesses that we need to be aware of as the nurse. So we need to be comfortable asking all women about abuse. So we need to talk about those safe questions that we talked about. We need to be comfortable doing that. These are uncomfortable situations for you and the patient. We need to listen to the accounts of abuse from patients and families. This can be extremely upsetting, disturbing. It can cause a lot of thoughts to run through your mind as the nurse. You're going to hear their stories, things that happens to children, things that happen to adults. And we have to be careful of how our face displays our reaction according to what we're thinking. So these patients are looking at you, they're trying to figure out what you're thinking. They don't want you to be judgmental of them. So we need to be careful of our reaction and contain our feelings, because we need to make sure that the person that we're really focusing on is the client. And that doesn't mean that you totally disregard what you think. There are times when you're going to go home and you're going to take these issues with you. That's the sign of a normal, caring person. But we just want to make sure that they don't ever supersede the needs of the patient, especially when we're dealing with them, because then it becomes about you and not about them. And then I think one of the most important things that we have to remember is that we cannot fix or change things. And that's very upsetting and very hard to deal with, because that's what we want to do. We want to help people. We want to fix things, and we want to make people better. And sometimes people don't want to be fixed and they don't want to change things. And that can be a hard pill for the nurse to swallow. So we just have to remember that our role is to listen and convey acceptance and support for the client. And ultimately, if it's not something that you can get past, then this probably isn't the field. This type of nursing is not something that you would want to do. And that's okay. We're all meant to do different things. Some things we can't do. We want to be able to recognize our patient's strengths, not just their problems. And then we want to work with perpetrators of abuse, because we want to be able to help them deal with their own feelings about abuse and violence, so we can keep it from reoccurring. All right, now I have some questions. Is the following statement true or false? A client with a history of violent or aggressive behavior is more likely to exhibit similar behavior in the future.
True.
True. Yes, that's right. During which phase does staff debriefing occur? The escalation phase, the crisis phase, the recovery phase, or the post-crisis phase?
D.
C, the recovery phase. So the debriefing occurs during the recovery phase to allow for discussion of the event, how it was handled, what worked well, or what needed improvement, and how the situation could have been diffused more effectively.
So what do you do in post-crisis?
That's when the patient comes back out of seclusion, you welcome them back into the thing.
Okay.
You can do a little debriefing then, but not as big as the other one.
Gotcha.
In violent families, which environment may be the most dangerous place for victims? Home, school, work, or church?
Home.
Home. Yes, home. Which type of abuse includes name calling and belittling? Psychological, physical, sexual, or sodomy?
Psychological. A.
Yes, A, psychological. The nurse assesses a client who comes to the emergency room for vaginal bleeding and swelling. The client reports she had sexual intercourse with her boyfriend the previous night and states it was consensual, but sometimes he is rough. The client begins to cry and looks away. What should the nurse suspect? Sodomy,
B.
intimate partner violence, family violence, or neglect?
Intimate partner violence. B.
Yes, B is the answer.
Intimate.
Yep, correct. All right, an elderly client with dementia lives with her daughter, but attends a day center during the day. The nurse notes the client is unkempt and smells of urine. Upon examining the client, the nurse notes bruising on the arms and back. From these observations, which type of abuse does the nurse suspect? Psychological,
B.
Physical.
physical abuse, that is correct. Which is the most commonly identified issue preventing people from leaving an abusive relationship? Dependency, emotional immaturity, jealousy, or possessiveness?
Dependency.
A.
Yes, dependency. Which feature would most likely predispose an adult to engage in family violence? The adult was abused as a child. The adult has been experiencing financial problems. The adult experiences chronic mild depression. The adult is used to being controlled.
A.
I think A.
A.
That
Yep.
that seems like an all the above kind of question too.
Well, I guess it could be, but most likely we know that more times than not, a person that engages in violence was also abused as a child.
That's true.
All right, a nurse is working with a client who has a history of repeated abusive intimate relationships. The nurse has difficulty understanding why a person would repeatedly enter into this relationship with abusive partners. When working with this client, the nurse can best maintain a therapeutic relationship through which approach? Keep focused on the client's feelings about the client's life situation. Honestly ask the client why the client repeats the cycles of victimization. Convince the client to develop a self-rescue plan, or not pry into the details of the client's private life.
Would be A.
The answer is A. Yes. So remember, we said that we're not going to understand why some people do things, and it might not be how we would handle things in life. But when we start thinking of things from that aspect, it becomes about us and not the patient. So we just always have to stay focused on the client's feelings. And I think we already, did we do this one? No.
No.
Okay. A nurse is caring for a child who had experienced sexual abuse, which are expected behaviors of a child who has experienced sexual abuse. Select all that apply. Avoidance of sexually related content, secretiveness of behaviors, open and honest discussion about history, high self-esteem, or distorted view of sex.
A, B, and E.
And E.
Who says A?
A.
Yes, it is A. Who says B?
B.
Yes. A, B, and then
And
E.
E.
Yeah.
Yes. Yep. Very good, guys. All right. We only went over by 3 minutes.